Welcome everybody to EHJ Today. My name is Jan Steffel. I'm Associate Editor of the European Heart Journal. We're here in Barcelona at the ESC 2014, and I'm very happy to be joined today by Martin Stockburger from Nauen and from Berlin, Charité, and by Michael Glickson from Sheba Medical Center in Israel. Good to have you here. Thank you for coming.
Yeah, thank you.
And we're here today to discuss the ANSWER study. The ANSWER study that was presented during this year's hotline session, and Dr. Stockburger came up with the study, so I'll ask you the first question. What was the idea behind it? Just to get everybody sort of on the same page, why did you come up with the ANSWER study?
I mean, I was a very early part of the CRT, cardiac resynchronization story, and as you know, early in the 2000s and even in the 90s, we were aware as a community of the importance of cardiac desynchrony. It's an important cofactor in heart failure. Mm-hmm. And so we know that we are causing desynchrony, and we're causing a left bundle branch block-like pattern of electromechanical activation of the ventricles by right ventricular pacing. So many require ventricular pacing, but maybe many do not require pacing. And there were some pathophysiological studies and also secondary analysis from pacemaker studies that appeared to confirm that concept, that even in the pacemaker patients, right ventricular pacing would produce heart failure. And the second concern was that it could produce atrial fibrillation. Yeah. Yeah. And then several different methods to prevent ventricular pacing have been developed. Among those were AV search hysteresis algorithms, and then also the AAI to DDD switch algorithms.
The MVP mode.
This was the first was the safe arm mode, actually, which and this was the mode which we examined also in the study. Okay. This mode switches automatically from AAI and adds ventricular pacing in case it appears to be required. Yep. And this is the case when there is no spontaneous conduction to the ventricle. And so it's a sophisticated algorithm. It has different situations when it switches. So it's a lasting long AV block, first degree AV block, with a programmable delay of 250 to 350 milliseconds. So it doesn't tolerate a very long first degree AV block. And the second thing is it switches if there are at least 3 out of 12 cardiac cycles not conducted to the ventricle. So this is a second degree AV block criterion. And then the third degree AV block criterion is if you have 2 consecutive cardiac or atrial sensed events that are not conducted to the ventricle. So it would switch also to DDD and add ventricular pacing.
And that's excellent. And tell us again, I mean, I've seen the presentation, but maybe for everybody else, the population that you studied this on was patients that were supposed to get or that got a pacemaker for a Brady indication, right? For an AV block indication.
We sought to actually include a very broad population. We wanted to have it quite representative. And at the time when we put together the study, we thought it was clear that patients with sinus node disease would benefit from such an algorithm, but it was virtually completely unknown what would happen to the AV block patients. You know, there are many AV block patients who require ventricular pacing only temporarily. So because they have only intermittent AV block. And we included half of the patients almost half had AV block, and the other half had sinus node disease. We were lucky that we ended up with this distribution. We didn't stratify and plan for that. But I mean, the patients were 72 years old. They had, on average, they had a normal ejection fraction. I mean, they were a pretty normal Brady pacemaker population.
And then what did you find? What was the main outcome of the ANSWER study?
I mean, we had quite a bit of a complex design. We had two co-primary outcomes. We had a technical outcome. We wanted to show that this algorithm works and actually does what it is supposed to do, prevents ventricular pacing in this whole population, in this general population. So the first endpoint was a technical one. Just the prevention or the amount of ventricular pacing. And the second primary outcome, so the clinical co-primary outcome was a combination of hospitalization for heart failure, because we thought heart failure would matter, and also hospitalization for atrial fibrillation or for cardioversion of atrial
hospitalization for atrial fibrillation.
So it was
not new onset of atrial fibrillation.
It was just to have it very strong and clinically meaningful. We went for hospitalization.
And what did you find?
I mean, we found that it was highly effective in preventing ventricular pacing. And this was the case in sinus node disease patients, but as well in those with AV block as the primary indication. So in sinus node disease, stimulation went down to from 98% to about 2%, and in AV block from 90% to somewhat over 50%. So we were very effective in preventing counted VP events. And the second and maybe more important part of the story was the clinical endpoint. So because this defines the clinical importance of the findings. And here you may just say it was a neutral study because we didn't meet the clinical combined endpoint. We had always the hazard ratios going in favor of pacing prevention, but this was not significant for the primary endpoint. And if we look deeper into that, we saw that we had quite the expected contribution of heart failure hospitalization. The study was not powered for heart failure alone, but we found in heart failure, we found what we expected. But the surprising part of the story was that we didn't find anything in atrial fibrillation. And I mean, this can be taken as a surprise, but in view of the DAMPACE study, another large study on pacing prevention done in sinus node disease patients only and published also in the European Heart Journal a couple of years ago, you could see that patients with under AAI pacing had more atrial fibrillation actually than those with DDD pacing. So I mean, it's always an interplay between the restoration and preservation of the atrioventricular sequence and on the one hand side, and ventricular desynchrony on the other hand side.
Maybe Dr. Lickson, you discussed the study. Obviously you've taken a deeper look into the data. What's your take on that?
Well, I think that the results of the study are generally in line with previous studies of similar algorithms, more or less. The technical success is superb. I mean, you reach almost 0% pacing in sinus node dysfunction patients. The effect in AV block patients wasn't very impressive. It was about 50% pacing. You may argue whether this suffices to give some hemodynamic advantage or not. And as you mentioned yesterday, maybe this 50% is not really 50%, but some of it is fusion, but let's leave it aside. Overall, the clinical results are somewhat disappointing, except for the first SAVE-PACE trial. The other trials did not show real advantage of minimization of RV pacing. And the question is why? And I have two potential explanations. One of them is a population explanation. Maybe these were the sinus node dysfunction patients that could have benefited, and the fact that we analyzed all of them together minimized this effect. And I guess that I'm sure that you will have sub-analysis of the results, and I can think that maybe the sinus node dysfunction patients will show will demonstrate effect, whereas the AV block patients may not. The other explanation is a more physiological explanation, as Martin has alluded to. If you end up with too long PR interval, and it doesn't have to be extremely long, it doesn't have to be 500, but even if you have a PR interval of 320, it may actually offset the advantage of pacing minimization. So we're probably looking at some kind of algorithm in the future that will take into account hemodynamics. I mean, you want to minimize RV pacing, but not at the cost of getting AV desynchrony to an extreme.
Yeah. I think that is a very good point. And as a matter of fact, that brings me already to my last question. On the one hand, it's a negative study, as you were saying, but on the other hand, you didn't see any safety issues. So there's really no reason not to use that algorithm. Is that so?
This is very important.
Exactly.
We actually could show that this is for a general pacemaker population. This is a safe algorithm, and even we had signals in the field of heart failure and the secondary endpoints that a patient could derive benefit from that, and that this also warrants further investigation. So we will go into the subgroup analyses, and we will do a detailed analysis on the PR intervals and the pacemaker stored PR intervals, because we have all these data, because those pacemakers we used store a lot of this stuff. So we are, I mean, it needs a lot of work has to be done, but I mean, we will have more results from the ANSWER study.
Excellent, and we're looking forward to that a lot. Thank you very much, Dr. Stockberg, Dr. Lixon. Thank you very much for being here today discussing this interesting trial with us, and thank you very much for watching. Bye-bye.